Good morning to you all. So I'll be touching on specific management aspects of the critically ill septic patient in the ICU. Moving on to case scenario, this is about a 58-year-old male patient coming to the ETU, giving a past history of diabetes, hypertension, ischemic heart disease, and being resuscitated in the ETU for septic shock secondary to a severe community-acquired pneumonia. So this is the initial blood gas done in the ETU setup, which shows hypoxia with a compensated metabolic acidosis with a lactate level of 3.6 and bicarbonate of 12 with a base deficit of 10. So this patient is being decided to be transferred to ICU for further management. So bit about ICU admission, it's very important to timely transfer a patient to the ICU once decided that the patient requires ICU care. Because interventions done in the ICU for septic patients are time critical. So any delay in administration of such therapy can result in increased mortality and overall poor outcome. So about this patient back, patient is now in ICU. The following are the clinical parameters on examination. He's a bit confused, spiking temperatures. Blood pressure is maintained with noradrenaline 0.1 running through a peripheral cannula. After 1 liter fluid resuscitation done in the ETU, found to have cold peripheries, saturating at 94% on non-rebreathing mask with 15 liters oxygen, but remains quite tachypnic. So once in the ICU, initial management is aimed at stabilizing the initial physiological parameters and to buy time for more detailed assessment and institution of specific therapeutic interventions. So monitoring of vital parameters, that is continuous blood pressure, ECG saturation, temperature and hourly urine output is very important. As previously also mentioned, invasive blood pressure monitoring is emphasized rather than non-invasive blood pressure. A patient is started on high flow nasal oxygen and a bolus of Ringer's lactate is started while inserting a central venous catheter. Blood samples are drawn for all the baseline investigations and a 12-lead ECG is done, and it is planned to repeat a blood gas in 2 hours time, 2 hours from the initial blood gas done in the ETU. And it is very important to talk to the patient and reassure the patient to relieve anxiety. So the first pillar of management of sepsis in ICU, of course, is antibiotics, which was discussed by Dr. Madhumani. So the second pillar is, of course, fluids. So the type of fluid, as explained earlier, is preferred type of fluid is balanced crystalloid. Ringer lactate is what is available in our setup freely. Albumin can be used, especially if the patient has already received large volume of crystalloids. But it has shown that there is no short-term or long-term mortality benefit. Colloids like hetastarch should be avoided. That is about the type of fluid and what is the amount of fluid. I'm sure you all are familiar with this 30 ml per kg within the first 3 hours. So this recommendation, which was a strong recommendation in the previous guidelines, is now downgraded to a weak recommendation. So then what is the volume that you're supposed to give initially? As you all can understand, all the patients coming with sepsis are coming with a fluid deficit. So they all can tolerate a bolus of up to about 500 ml or even 1 liter to start with before you assess fluid responsiveness. But after completing about 1 liter of fluid, before going for this 30 ml per kg bolus, before going for completion of this bolus, you have to always go for assessment of the fluid responsiveness. So fluid responsiveness by definition is a stroke volume increase of at least 10% following a bolus of 500 ml in 15 minutes. So how do you assess fluid responsiveness in our setup? You all know there are these static and dynamic parameters, out of which dynamic parameters are preferred. So these are the commonly available, more freely available dynamic parameters: the passive leg raise test, IV collapsibility, bedside cardiac ultrasound, and pulse pressure variation. Apart from these dynamic parameters, you also have to assess the patient very closely for other clinical parameters which help in deciding the volume of fluid the patient requires. These are some of the parameters include capillary refill time, cold peripheries, skin mottling, confusion, excessive thirst, dry mucosa, oliguria, tachycardia, low blood pressure, and lactate levels. What I want to emphasize is that don't go by just one or two parameters. Don't just stick to IVC collapsibility, which is a common practice in our setup. But you have to assess the patient, look at the big picture, and get a better idea of the patient's volume responsiveness. The third most important aspect is vasoactive agents. The target map is 65. The previous guidelines they gave a target map of above 65, but now what they mention is 65 because trying to maintain a higher map target using vasoactive drugs is not going to add any benefit, but can cause unwanted side effects of the vasoactive agents. But there may be some other compelling indications where the patient needs a higher MAP target, like those with chronic hypertension, to preserve renal function. So the number one choice of vasoactive agent is noradrenaline, as you all know. But if you need a second agent, you have to consider vasopressin. Generally, in sepsis, the second option is vasopressin, unless there are any other compelling indications that require the use of adrenaline or dobutamine. If the patient has myocardial dysfunction, then you can consider dobutamine or adrenaline. You can consider adding dobutamine onto noradrenaline or use adrenaline as a sole agent. But when using dobutamine and adrenaline, you have to keep in mind the unwanted side effects of these agents, which include risk of tachyarrhythmias, specifically with dobutamine and adrenaline. Little bit more about noradrenaline. It's the popular agent, alpha-1 beta-1 adrenergic agonist with predominant vascular level effects, but also has some effects to improve myocardial contractility and cardiac output. So, the timing of initiation of noradrenaline infusion, you don't have to wait until you complete your fluid resuscitation to start your noradrenaline. What they recommend is it's better to start noradrenaline early, like within the first hour, while continuing with your fluid resuscitation, which have some other benefits, additional benefits, rather than just simply maintaining the MAP target. Noradrenaline has the potential to improve coronary perfusion, and also it resuscitates the microcirculation, which is the therapeutic endpoint of managing sepsis. And it also allows administration of a rather small volume of crystalloids, thereby reduce the risk of fluid overload. And overall, noradrenaline has the potential to improve mortality and shorten ICU stay. And importantly, as previously mentioned also, it's recommended to have an invasive blood pressure monitoring if the patient is in shock and requiring vasoactive agents. And also, you don't have to delay starting vasoactive agents until you get the central line in. You can start noradrenaline peripherally if it is indicated until you get the central line set. So in the bottom line, still, even after several updates to our guidelines, the total amount of fluid that should be administered still is under debate and remains incompletely defined. The resuscitation endpoint being restoration of microcirculation. So, a reasonable approach to be applied would be to administer initial bolus to feed the deficit of the patient, and then to go with relatively smaller boluses, maybe 250 to 500, while assessing the fluid responsiveness. And in the meantime, while continuing with your fluid resuscitation, you can start your noradrenaline if the MAP target of 65 is not reached. And also, you have to repeatedly reassess the patient. Repeated reassessment is very, very important. And also, keep in mind that you have to prevent occurrence of fluid overload. So, back to our patient. After 8 hours from ICU admission, patient shows some improvement in clinical parameters. GCS is improved. Now it's 15 out of 15. He's stable on high flow nasal oxygen, respiratory down to high 20s from high 30s, and blood pressure is stable with a map of 70, and heart rate is down to 114, still with uh, noradrenaline 0.45 mics. And more concerningly, the urine output is reduced. For more than 6 hours, he remains oligoanuric, and the creatinine has risen to 200 lots from a baseline of 88. And this is the uh, blood gas report after the initial fluid resuscitation, showing uh, a downtrending lactate level, which has come down to 2.5 from 3.6, but there is worsening metabolic acidosis, which he is compensating with carbon dioxide washout. The BSXS has increased to -12 with a bicarbonate of 10. So, what is your management? The patient seems to be adequately volume resuscitated, but now he's being pushed into a renal impairment. So, reassessment is very, very important, as I always mention. Now, this patient has got warm peripheries, his thirst is improved, capillary refill time is acceptable, GCS remains at 15, MAP is maintained, but still with NORAD 0.4, and saturating fairly all right, but remains tachypneic. So the patient is having an adequately filled system, but is in AKI. So what are you going to do? Are you going to give him a session of dialysis? Renal replacement therapy in septic AKI. Initiation of renal replacement therapy, that is timing of renal replacement therapy, again is controversial. Early versus delayed initiation. Available data show that there's no difference in overall mortality by early initiation or delayed initiation of dialysis. There is this large randomized control trial which is in progress at the moment, and the results are later. What about sodium bicarbonate? Again, this is a controversial area. It is mentioned to be appropriate when there is severe metabolic acidosis, as indicated by a pH of less than 7.1 and bicarbonate less than 5. But if there is significant lactic acidosis, use of bicarbonate is discouraged. You can use bicarbonate in lesser degrees of acidosis if there is an associated moderate to severe AKI. So in our patient uh, who had developed moderate to severe degree of AKI following adequate fluid resuscitation, we tried with some bicarbonate in isotonic solution, for which he responded fairly all right, and he started passing urine after a bolus of furosemide. So we could save the patient from requiring a dialysis. Little bit more about other aspects of management. Immunoglobulins are not indicated, not recommended, and insulin therapy is very important. Tight uh, glycemic control, targeting blood sugar of 140 to 180 is recommended. And don't forget your corticosteroid when the patient requires a NORAD dose above 0.25 mics per kg per minute for more than 4 hours. You don't have to wait until the patient requires all 4 inotropes to consider your steroid. My take-home messages would be about fluid resuscitation. I wanted to highlight that clinical judgment is very, very important. Don't just go by only one or two parameters. Use all available clinical data as well to decide individualized fluid management. And noradrenaline, you have to consider early. Don't delay it until you get your central line in. Please start it through a peripheral line. Actually, in later guidelines, they are considering out of hospital initiation of noradrenaline even. It is that important. And also, don't forget the kidneys. Uh, Sepsis is the commonest cause of AKI in critically ill patients. Up to about 60% of patients with septic shock develop some degree of AKI, and out of them, a significant proportion requires renal replacement therapy. A subgroup of whom will require uh, long-term dialysis as they progress into CKD. So always look into your MAP target. Don't forget bicarbonate. Consider furosemide. A properly timed small dose of furosemide can do wonders in septic AKI. Always look for the drugs, nephrotoxic drugs in your drug start, and timely transfer to ICU is very important. And don't ever forget the family update. always have an update for the family that relieves anxiety and helps in overall patient management.